Okay. Let's see. Okay. So you guys can see my screen, right? I'm sharing my screen.
Yes, I can see it.
Okay, perfect. So I wanted to set up this presentation so you guys can kind of get a more feel of understanding of the utility of pharmacogenomics. I know a lot of people do PGX testing, or maybe you guys don't already, but just kind of understanding when you're looking at a PGX report and all the genes, how kind of that you can interpret the results and kind of understand there's a patient behind the PGX report instead of looking at the raw data. So it's kind of trying to give you a little bit more understanding of the background of that. And just for you guys who don't know me, my name is Behnaz Sarrami. I'm a pharmacist by trade, but I'm a medical science liaison for a PGX lab company. So so what I really do all day is create educational content so I can educate and have presentations like these, whether in person or on a Zoom meeting, to clinicians to understand the value, the utility of PGX and how they can implement it in their practice, and also to obviously the sales reps who actually go present that piece. So so my job is really awesome, creating educational contents all the time. Well, that's my main job. But so let me minimize you guys over here. So just kind of give you an overview of the mental health in the US and how prevalent it is. So 1 in every 4 women and 1 in every 6 men actually are diagnosed with some kind of depressive disorder, and 1 in every 8 age over 12 are on some kind of antidepressant. And unfortunately, because of COVID, that that number has been exacerbated. So we just have a lot of mental health issues around the United States. So getting patients kind of mentally stable is really key. So as you know, there's a lot of trial and error processing when it comes to mental health prescribing. I'm going to kind of be using fluoxetine or Prozac throughout my presentation to kind of be a little more consistent. So based on when a patient comes in and they present with kind of depression or anxiety, they're, based on the medication side effect profile or the clinical judgment of the prescriber and the clinical presentation of the patient, a medication is selected. So let's say antidepressant A, which is Prozac, they are put on the patients put on Prozac. They're told to come back within 4 to 6 weeks, see how that's working for them. And there's been a lot of studies done that the first trial that a patient goes on a antidepressant, half of those patients don't really get any relief or no response. So the patient comes back, goes on antidepressant B. So they're either augmented with another medication or switched over to something else. And then they're told to come back another 4 to 6 weeks. So this really cycle of trial and error process keeps going until a medication is selected. So what pharmacogenomics does is combine the science of pharmacology and genetics to personalize a patient's medication. So then we're cutting back those amount of months that it takes a patient to become mentally stable, and that's really the key. Here's a case study of Michael Adams Conroy. He was a 9-year-old boy that was adopted into a really nice family. He came from an abusive family. So he had a lot of mental health issues. So he was put on Prozac. Eventually his dose was moved up all the way to 40 milligrams a day. He was doing better, but he had a lot of side effects, started having a lot of side effects like hallucinations and aggressive behavior. And so unfortunately he went to the hospital and he passed away. So he was a poor metabolizer of a 2D6, which we'll talk about, an enzyme. And he had Prozac toxicity, and that's what he died from. So if you look at Prozac, so here's my mouse. If you look at Prozac, I know it has a lot of, a few CYP enzyme that it goes through for metabolism, but the main one is the 2D6. So fluoxetine uses 2D6 to metabolize to S-norfluoxetine. We don't really care for the name, but that's what it goes through. But also if you look here, it inhibits its own metabolism. So it goes through this little cycle of metabolizes, inhibits its own metabolism, metabolizes, inhibits its own metabolism, which is why Prozac has a long half-life and stays the body for a long time, because it inhibits its own metabolism. So if you think back on that 9-year-old boy, he was a poor metabolizer of 2D6, meaning he's not able to convert the fluoxetine into the S-norfluoxetine. So he had a lot of buildup on the left-hand side. If you imagine like filling up your sink with full of water, but then not be able to drain it. So that's what was happening, and that's what he died from. So I wanted to kind of step back and define metabolism, since we talk a lot about that. So if you think of what metabolism is, what the body is trying to do is get rid of that medication out of the body. So it does, it wants to make it more water soluble, so it's easily excreted out of the body. So that's what metabolism, the idea of metabolism is. And this chart is used for medication that are already active. So let's say if on the far left, if you're a poor metabolizer, if a patient's a more poor metabolizer, they're getting rid of that medication very slowly. So the body is actually retaining a lot of that medication, which is why on the left-hand side, on the bottom, you see only one pill. Versus all the way to the far right, if someone's a rapid metabolizer, they're quickly getting rid of that medication out of the body, where the body doesn't have enough chance to actually absorb the benefits of all that medication. So that's why you'll see 3 pills on the far left-hand side. So that means you would need to increase the dose for that patient. So kind of think that for active medications. So when it comes to inactive medication, we'll talk about in the idea of phenoconversion, we'll talk about that as well. So phenoconversion is actually called the blind spot of pharmacogenomics, and I'll explain that in a second. So here's a case study of a 55-year-old, or I think 52. She had cancer and she had surgery, but she was given a pain medication, Tylenol number 3. So if you see, Tylenol number 3 has codeine in it. So codeine is an inactive medication. It uses, if you look far right here, it uses 2D6 to activate. And that 10 just means the affinity of codeine to that CYP enzyme. So it uses codeine. Let me go through this chart, maybe make a little bit more sense. So codeine uses 2D6 to convert to morphine, because it's inactive, to be able to give the pain relief. So when you take Tylenol 3 or anything that has codeine in it, it has to convert to morphine to give the pain relief, and that's used by 2D6, and then a whole host of other routes that goes through to make it more water soluble, to be rid out of the body. But you need to be able to convert and have this process going. So what happened was, she's a normal metabolizer of 2D6. She's able to convert just fine, but she actually gets a little depressed because of her situation, and she's put on fluoxetine or Prozac. So what happens, if you look right here, fluoxetine actually uses 2D6, like we talked about with the 9-year-old boy, 2D6 to metabolize, but it has a stronger affinity to 2D6 now. So that means fluoxetine is taking over. So this person is no longer able to convert the codeine to morphine, because fluoxetine, there's that competition, and fluoxetine, because of the percentage is 40, it wins over. So we just converted a normal metabolizer of 2D6 to a poor metabolizer because we added another medication. And that's the idea of phenoconversion. We phenoconverted this normal metabolizer to a poor metabolizer because of an added medication. So understanding kind of when you're looking at a PGX report or any drug-gene interaction, and how the genes play into, like, their normal metabolizer, rapid metabolizer, but also the drug interaction piece and how they play together is really key. So because she's no longer able to convert codeine to morphine and get pain relief, she obviously, her pain was back. They added flecainide that has a little bit of analgesic effect. So now you see we have 3 medications that are competing for the same CYP enzyme. But you would think fluoxetine wins over because the percentage is higher, but flecainide's dose is higher. So now she's not only able to convert codeine to morphine and get pain relief, she's also not able to get her depression and anxiety under control. So what really needed to happen was she just use an active form of codeine, which is morphine, and just stay on fluoxetine. So you can see, again, kind of taking a raw PGX report, you have to look at the patient, you have to see how they're clinically presenting, you have to see the drug interaction and kind of put them all together and connect the dots, not just look at a report. And then the other thing is really always talked about is epigenetics. But I want to pause here to see if you guys have any questions that I can answer before I move on, or otherwise guys can always interrupt and ask questions if you want to. Does anybody have any questions I can answer so far? Okay, so the other idea that's talked a lot about, which I don't know if a lot of people are aware, is the idea of epigenetics. Epigenetics. So epigenetics is really any environmental factor that changes the way our genes work. So environmental factors mean like it could be stress, it could be smoking, it could be drinking, any kind of environmental factors that affect the way the genes work. That's the idea of epigenetics. So how it came about is actually, if you Google hunger winter, it's a pretty cool story. Well, not cool story, but it's nice to read. It's end of World War II, German occupied Netherlands. They were really cut off from food, and so some people had only access to soup. So you can imagine a lot of people died of famine. So what scientists wanted to find out is how the effect of famine on human health. And they figured out that children of pregnant women that were exposed to famine, which is a environmental factor of being, stressed out, not having food, things like that, those people were more susceptible to health issues, mental health issues, diabetes, cardiovascular issues, a whole host of chronic conditions. So what was happening with epigenetics is methylation. So kind of you have to, when you study epigenetics, you have to study methylation together. So what was going on was a lot of methylation was happening. And so why methylation is important, it does a lot in the body. It regulates, this is not a full list by all means, by any means. So it regulates how we respond to stress. It regulates, again, how our genes turning off and on, regulates mental health, which we'll talk about a little later. And there's been a lot of studies because of COVID around immune function, immune support. So if you look at my angry COVID virus in the middle, if you think of methylation, the process of immune support is, think of it as putting kind of a little cap on those spikes and neutralizing the virus so the body can fight better, right? So that's the idea of methylation. So methylation is really adding a methyl group onto cysteine, really. That's really all it does. But methylation actually decreases as you age. So if you look down here, these little black circles, I guess, we're highly methylated as we're younger. So what happens is kind of, if you think of it as kind of blocking the space between the DNA and kind of everywhere, versus as you age and also environmental factors, as you see, methylation decreases. So now you have this open space in the DNA for mutation to happen. So that's kind of the idea. But you can be over methylated, because a lot of people, when they found out about this, especially with COVID and immune support, they wanted to increase methylation. But the idea is there's a nice balance also, because you can over methylate and have this, the paranoia and anxiety, or you can be under methylated. So finding the right balance is key. But where do you actually get the methylation from? This is my favorite cycle. I know in chemistry we studied a lot about Krebs cycle and whatever cycle, but this is a really cool cycle because it's called the folic acid cycle. So what happens if when you ingest, and this is where methylation comes into play and where you get the methyl group to methylate. So when you ingest a folic acid or folate, which are both inactive, so folate, and the difference between the two is folate is found in natural food that you eat, versus folic acid is a supplement, so it's man-made. So if you take any of those two, they're inactive. The body has to be able to convert that to an active methyl group or active folate to be able to use it. And so that uses the enzyme MTFHR, if you've heard of that. MTFHR converts the inactive folate or folic acid into this methyl THF, which is an active form of folate. Trying to find my mouse here. There you go. And it combines with the B12 that you already have in the body with the small amount of homocysteine in there to combine to convert to methionine, which does a lot of protein synthesis, which eventually the idea is to get to SAMe. SAMe is the one that actually gives you the methyl group, and COMT, which is another enzyme we'll talk about, or COMT, is the one that actually does the process of methylation. So you need to go, so your body goes through this cycle to be able to convert the folic acid or folate that you're ingesting to get to give methyl group and methylation. So that's why some people actually supplement with SAMe to be able to just skip that whole cycle and just take this supplement to be able to provide that. So you can imagine if your MTHFR is not working properly, this cycle is not efficient, and you'll have a buildup of homocysteine, which causes a lot of inflammation in the body. And for a lot of pregnant women, it can cause a lot of child bearing issues. So that's why a lot of people actually get their homocysteine levels checked as well. So take the case of a 32-year-old female. She has hypothyroidism and anxiety. So her MTHFR gene, she's a heterozygous for MTHFR. So that cycle we talked about is not efficient for her. She's not able to convert very efficiently. So she was put in, if you look right here, the active form of folate, which is methyl tetrahydrofolate, 8,000 microgram, and given B12. But it took, if it took from August 2014 all the way to February 2015 to get her mentally stable. Why? Because over here she was over methylated. So if you see the dose, it was decreased to 500. She was given liquid B12 and added SAMe. So this is how you can use that MTHFR report to kind of see if nothing else is working for this patient, because she was on Xanax, I believe, for anxiety. It wasn't working for her. So that's another clue you have in the PGX report. Again, PGX is a small piece to guide you in the therapy. So let's talk about COMT and the link to ADHD and dopamine. But kind of, I like to kind of go back and explain where everything comes from. I think it gives a little better understanding of where dopamine comes from, which is tyrosine. So just to kind of orient you, this is the presynaptic cleft. I'm sure you know, this is the postsynaptic, and this is the synaptic space, I guess. So dopamine is made from tyrosine. So when it's made right here, it's stored in these little vesicles, which you can't see, for when it's needed to be used. And when it is needed, it goes to this VMAT. We don't really care about the name, but it goes through a transporter to be released into this space right here. And so then when it's released into space, it attaches to its receptor and causes an action. And then when it's no longer needed, it gets picked back up by a different transporter called DAT and goes back into those stored vesicles. Or they can, for future use, or they're metabolized or broken down by MAO and COMT, which we talked about. So COMT, again, uses the methylation, like puts a methyl group and causes the dopamine kind of to be broken down, right? So this is what methylphenidate or Ritalin does, is actually blocks the DAT receptor, a transporter, so dopamine cannot be picked back up, and so you have a lot more dopamine out in this space. Versus Adderall or amphetamines, it not only blocks the DAT transporter, but also the MAO enzyme, so you don't have the breakdown. So now you have more dopamine everywhere else, which is why it's a little more potent, right? But also, amphetamines that have similar structure to dopamine, so some of them can actually be picked up by this DAT receptor, transporter, back up into this presynaptic cleft, and it can go into these little vesicles that have the stored dopamine and burst them open, and you have more release of dopamine. So that's where that idea comes from. But the COMT, as we look right here, it's what gets rid of or metabolizes or breaks down dopamine. So if you look at COMT in biology, I think we learned that sometimes, or most of the time I should say, if you look at a name, the way you figure out what the function is, to kind of read it backwards. So if you see, sorry, I'm trying to look for my mouse here, it keeps disappearing on me. So if you see COMT, which stands for catechol O-methyl transferase, if you read it backwards, you can see what it does. It transfers a methyl group onto a catechol. So catechols are like dopamine, epinephrine, and norepinephrine, right? So those are your catechols. So it's transferring a methyl group. Again, we studied methyl group kind of inactivates chemical. So they called the COMT more of a personality gene. So if you have a slow version COMT, meaning it's slowly breaking down those catechols, or let's say dopamine, just for simplicity, it's slowly breaking down dopamine. So that means you'll have a buildup of dopamine in that synaptic space. So these individuals have more of the warrior with the O personality, that kind of more worried, stressed out in a situation. That doesn't necessarily mean it's a bad thing that they thrive in that environment. And so I'm not going to go through the nutrition part, but just kind of let you know that there are exercises for individuals that have these kind of, I guess, personality, which would be more calming exercises such as yoga, versus it's been studied that patients with ADHD have the fast version of the COMT, meaning it's quickly getting rid of that dopamine. So there's not enough dopamine out in that space, which is why it's kind of counterintuitive to give a stimulant to a patient who has ADHD. But if you think about that right here, it's blocking that DAT. And so also their COMT is acting very fast, breaking down dopamine really quickly. So these individuals have more of the prone to depression, addictive behaviors. They're calling more warrior with the A. So they can benefit from exercise, like competitive exercises such as karate. And then, as you know, some individual use nutrition to manage their ADHD. So that's what the COMT is for. So when you see it on a PGX report, you don't necessarily mean you have to do anything with that, but that kind of gives you an insight of what's going on. So here's the last pharmacodynamic gene I'm going to talk about is the SLC6A4, which is the people talk a lot about it. So it's a serotonin transporter receptor. So if you look up here, what, normal, quote unquote normal. So if you think of the same thing, this is serotonin in these vesicles, but same thing with the dopamine we talked about. They're stored in these vesicles. When they're needed, they're released out of this SLC6A4 transporter. They bind to the receptor. And then when they're no longer needed, they're picked back up and then go back into the vesicle. So if someone with depression, they actually don't have enough serotonin in this space, right? As you can see. So what the SSRI does, or selective serotonin reuptake inhibitor, it blocks that transporter. I lost my mouse again. It blocks that transporter, so serotonin is not picked back up, and there's more in that synaptic space. So if you think about someone who has the variant gene SL664 that's short allele, they have the short version, it appears it appears somewhat like they are already on an SSRI. So let me explain how that works. So assume this doesn't say normal, it says like SLC64 short allele version of the patient, right? So what that means is this SLC6A4 transporter is short, meaning it can't further extend out to pick up the serotonin and put it back in the vesicle. So there's going to be a little bit more left over in that synaptic space. And also there's not enough transporters on the presynaptic cleft right here. So if you don't have enough of these transporters to pick back up, and they're short, they're not long enough to pick more of them. So you're going to have a lot of serotonin out in the space. So these individuals appear like they already on an SSRI. So if you give them an SSRI blocking that receptor, you're increasing more serotonin in that space. So they're going to see more of the side effect profile of an SSRI, and they're not going to get a lot of benefit from it. So this is another way you can assess if someone is on, if they're normal 2D6 or 2C19, their normal metabolizer, why isn't their SSRI not working, or they have a side effect? This could be another clue into that. The last thing I'm going to say is really for those of you guys who already do PGX, the power of kind of sharing that with everybody in the team. So not everybody gets their mental health medications or psych medications from their psychiatrist. They can get it from their OBGYN, from their primary care. So being able to kind of share that report with everybody, not only does it educate other clinicians as to what PGX is, but we had this case where a patient did a PGX test in a psychiatric clinic, but they took the report with them, and they were a poor metabolizer of 2D6, and they had a heart condition. Patient was their cardiologist was going to put him on metoprolol. Metoprolol uses 2D6 to metabolize. So we had to get involved as to kind of educate that cardiologist as to how that may play a part in their metoprolol, and probably not a good idea to use metoprolol, or maybe an increase in dose may be indicated. So kind of sharing that with all teams, providers is really helpful. So that's really all I had for you guys today, to kind of understand the utility of using a PGX again, instead of looking at the raw report and just kind of making a decision, and being able to kind of connect the dots and use drug-gene interaction, drug-drug interaction, look at the patient clinically, and then use PGX as another tool, like a guide we have, like diabetes guidelines we have, or any other guidelines, to be able to kind of decide what that looks like for your patient. So do you guys have any questions I can answer, or anything that's not clear you want me to go over again for you? Okay. So am I sharing the recording? Yes, so I recorded it for people who can't be on the Zoom meeting, because some people are working perhaps, or different time zones. So yes, I hope to share that. And I will share a link for you guys, or figure out if the link, if the it's not too big of a megabytes, or whatever the acronyms are, I can email it. Otherwise, I'll probably put it on a YouTube and share it. I don't know. I'll see how big the size is. Do I have a sample PGX report to show? I do. Let me get to one. That's a good question. So you guys can see my screen, right? I think you can. Okay, so you guys can see my screen, right? This is a sample PGX report. Is that correct?
Yes.
Okay, perfect. All right, so this, well, here, I'm gonna go to the bottom just to show you the, okay. So this is what the gene, well, I work for Althea DX, so they're a PGX company, so this is their sample report. I can't speak for others, but this is the sample report. So it has the 2D6, it has the CYP enzymes we talked about, the 2D6, and the other pharmacodynamic genes, like the COMT we talked about here, MTHFR we talked about here, the SLC64 we talked about here, and OPRM1 is for pain. Let's see, like ABCB1 is the PGP efflux system, if you guys remember from a million years ago from biology. So efflux system is the one that anytime you ingest a medication or any foreign substance, the body has a defense mechanism where it spits things out. So you have a lot of the PGP glycoprotein are in your gut. So before it actually goes to your blood system, it wants to make sure it's it's not getting there. So you have a lot there, and also in the brain. So before it gets to your blood system or your brain, the PGP efflux system spits things out. So the better your ABCB1G works, or your efflux system works, the more you're spitting out the medication, so you have less absorption. So hope that makes sense. And then the ADRA2A is for the stimulants metabolism. And yeah, so if there's clinically significant for any medication, if, for example, this person is a 2C19 poor metabolizer, right, it would show up on a report. So I'm going to go back up here. Just go in the depression section. So these are the medications that on the left-hand side underneath the green that don't have either a drug gene interaction or drug-drug interaction. But if you go on the right-hand side on this orange or light brown color, whichever color you see, you have medications that have a drug-gene interaction or a drug-drug interaction. So this patient is actually on citalopram, which is why it's black, versus if you were to select any of these medications to put the patient on, it just tells you caution because of X, Y, and Z. So if this person is on citalopram, let's say, and it says 2C19 poor metabolizer, it says like reduce the dose or use an alternative medication that doesn't use the 2C19. So there are a few SSRIs that use 2C19 to metabolize. So this person was a normal metabolizer of 2D6. So you could use fluoxetine, for example. Or if there's clinical indication to keep the patient on citalopram, you can reduce the dose. It's a starting dose of reduce it by 50%, right? So if they're poor metabolizer, they're not getting rid of that medication, so they're already going to have a buildup. So you want to start lower and go up. And then talks about COMT, and then also tells you it's gotten from CPIC guidelines, or you can read the reference here. And then also because there are poor metabolizer of 2C19, for example, tells you to stick to 20 milligrams a day max because of QT prolongation. So it kind of gives you, our report gives you a comprehensive data on the right-hand side of what to do. So, but this is just the depression section, like it goes through different section depending on the clinical indication you're looking for, bipolar, and it keeps going. But then we also have a drug-drug interaction piece, which is unique to Althea DX. It tells you, like, obviously you can't take fluoxetine, citalopram, but it doesn't give you detail as to why, just because, as you guys know, there's sometimes clinical indication as to why a patient can be on two medications that have, drug-drug interaction, but there's clinical indication as to why that is. So here's what I meant by, this person is a 2C19 poor metabolizer, but I think everyone on the call is a pharmacist. So when I had my collaborative practice agreement, I sit with the patient, go through all their medical history, all the medications they're on, see what their challenges are, where they're at, what they're trying to achieve, because this person could be on citalopram, a higher dose, and they're a 2C19 poor metabolizer, but they're doing just fine. So just because I see this raw data in front of me and I haven't seen the patient and how they clinically present, I'm not going to take the person off of citalopram or reduce their dose or anything like that. I have to make sure I just have this piece of a PGX puzzle as another tool to use to make clinical decision. Just like I said, like we have diabetes guideline, but not everybody can start off with metformin. You got to see what that looks like for them. So yeah, here's a sample report. Hope that answers your question. If you guys have any other question, I can answer. If you guys think of anything else, you can always email. I think you guys have my email. I can answer questions. And Danielle, I think you had questions before, so we can talk after about the cost that you were asking me. I appreciate everybody being on the Zoom meeting today. You guys have a great evening, and let me know if you guys have any questions I can answer or any comments. I'm trying to host these like once a month maybe, or twice a month. So if you guys have any topics you'd like to see or hear or more of this, just let me know. I hope this was helpful for everybody.